Welcome. Well, I'll go ahead and get started as people introduce themselves and share where they're at in the world and what you do. We're so glad that you're here. And Catherine, thank you so much for being here with us.
Yeah.
It is an awesome opportunity to get with providers, share some knowledge. It's wonderful when we can do this. So welcome. Return to Zero is happy to be here, and my name is Jennifer Caton, and I am also, I work with Return to Zero as a community support person, so I lead support groups. I'm also a baby loss mom 5 times over. I was thinking about it this morning, and I thought it'd be interesting just to share, because this is a provider-focused webinar, that I had 5 different providers in 6 different pregnancies, and both in Los Angeles as well in the Seattle area where I reside now. And I was lucky enough to have a miracle baby, Josie. She's 5 years old now, still absolutely incredible and here with us. And anyway, just want to share a bit about myself. And so today we are talking about the intersections of perinatal trauma and loss for healthcare providers. And so what this looks like is supporting clients after pregnancy or baby loss can be both the most cherished and difficult work that you all do. It's difficult to believe that not everyone or every client that you encounter may have their trauma and grief experience at the forefront of your work. And unfortunately, sometimes providers create additional trauma with or without realizing it. And that can happen through the impact of words or actions or both. So in this webinar, we're going to look at the types of trauma that commonly occur in the context of perinatal loss and how birth trauma intersects with the already traumatic experience of perinatal loss, pregnancy or baby loss. So we will conclude with some action steps as well, and that you can take with you to reduce avoidable traumas and hold space with clients through unavoidable traumas. So feel free to get your questions ready as Catherine kicks this off and shares her presentation with us. Please feel free to share your questions in the chat, and we will address them towards the end of the presentation. All right. Pass it to you, Catherine.
Thank you so much, Jonathan. I'm gonna bear with me just a moment. I want to share the correct screen. Okay. So again, client trauma and perinatal loss. We're going to be looking at this from a provider perspective today. And I tried to find a balance. I'm so glad to see the diversity of attendees today. I tried to bring in a balance of mental health providers who might be encountering clients sharing their experiences in the therapy setting or debriefing with a mental health provider, as well as medical healthcare providers, because the two different types of or kind of wheelhouses of professionals who encounter client birth traumas are going to have a very different experience and also different capacity to make change to help clients heal and to give them better experiences. A little bit about me. I'm Catharine McDonald. My pronouns are she, her. I own Growing Well Counseling in Tallins, Connecticut. We're an exclusively perinatal mental health practice with a focus on loss and infertility struggles, birth trauma, and integrative perinatal mental health. I've been licensed as a professional counselor since 2010. And on a personal note, I identify as a gravid of 7, par 4. I had 3 losses in between my 3rd and 4th baby. And I'm here sharing this presentation with you today because I had the privilege of access to a life-saving D&C when I had a molar pregnancy. So I'm very grateful for the care that I received that allowed me to continue to be a mom and grow my family and do this work. So peripartum trauma is, as Cheryl Totano Beck is a nurse, midwife, and researcher out of the University of Connecticut, and she likes to say it is in the eye of the beholder. We don't want to add to or create trauma when we explore peripartum trauma. So no matter what role you're in professionally, it's really important to lean back and listen and not project our own traumas. Um, so I don't want to say, oh my goodness, that sounds awful. That was terrible. Or what about this? And I don't want to direct a client and add to something that maybe wasn't there. It's really important to sit and listen as much as we can. If you have a direction or an inquiry, something you're wondering about, come from a very curious place. Tell me about that. Or I want to hear a little more about that. How was that for you? If you have an inkling, maybe as a healthcare provider or a personal lived experience, what was that like for you to hear that? What did it feel like in that moment? As opposed to that was horrible, or what about this? And not never leading our clients to create additional traumas. What do we mean by trauma? So at baseline in general mental health, a trauma is any experience or event that exceeds one's coping capacity, can create intense fear, anxiety, panic, distress. It is highly subjective, and it can be both witnessed or experienced. It's really important to remember that birthing, non-gestational birthing partners, the father, significant other, anyone who's not necessarily pregnant or giving birth also is at risk of a trauma. And then additionally, we have healthcare provider trauma. It can be incredibly traumatic to fear that you might lose a patient or come pretty close to losing a patient. And then in baby loss, stillbirth, the actual loss of the neonate patient. Penny Simkins says that a birth is said to be traumatic when the individual believes the mother or baby's life was in danger or that a serious threat to their physical or emotional integrity existed. We want to think about all the different perspectives. If we were above looking in, who are all the different people in the room and how did they see and experience what the trauma may have been? And that can be in an ultrasound room, receiving news, in a physician's office, getting a report or an update, in a procedure room or a labor and delivery room, in a NICU. There are many settings in which we're looking in and thinking, who are all the people involved and what are their unique experiences? What was hard uniquely for them? And how does it differ? A key part of couples work is honoring that the birthing and non-birthing person had a different experience and different things were scary and traumatic. And the research does show us that the vast majority of non-birthing partners, the research is typically heteronormative cisgender males, is reflective of a non-debriefing, non-informative approach. The vast majority of non-birthing partners don't get enough information. They felt they were left out and they didn't know what was going to happen. When someone is not a medical professional and doesn't know what's happening, things are urgent, emergent, there are a lot of people, there's a hurried pace, it can be terrifying, and that person's mind can quickly wander away from them. And I've talked to more than one non-birthing parent who said, I thought I was going to lose both of them. I absolutely thought they were both gone and my whole family had just died or was about to die. So being really thoughtful when you're doing work, thinking about everyone and what traumas were subjective to them is a really important part of this work. This is by far not an inclusive list, but some of the common traumas, which I call different difficult, include miscarriage or chemical pregnancy, and that these descriptions or generalizations are by absolutely not intended to be all encompassing, but just some trends that I kind of see. With a miscarriage, there can be traumas of unexpected blood loss. A lot of clients are uninformed or underinformed as to what to expect. And then there's the loss of what was going to be, and it's often silent. Many people didn't know with those early pregnancy losses that someone was pregnant. So there's a lot of isolation, and there's great variability I found in healthcare provider follow-up. Unless someone's hemorrhaging, some doctors' offices say, well, call us if you don't stop bleeding in X number of weeks. People get very inconsistent advice. If someone is given medication at home, they may be traumatized by not being prepared for the quantity or intensity of the cramping and the blood loss, the size of clots and things like that to expect. In a molar pregnancy, there is often a process of not quite sure what's going on, something's not right, a lot of invasive potential ultrasounds and trying to determine what's happening. And in a partial molar pregnancy, there may be a fetus that appears to be developing. We know from the science that in a partial molar pregnancy, the remaining fetus will not survive. And that can feel like a completely different kind of devastation, or to prevent the woman from serious complications or potential cancer, like gestational trophoblastic disease and choriocarcinoma. They need to terminate a pregnancy, and on an ultrasound, they're seeing what looks like a healthy baby. And in the post-Dobbs world, that gets really complicated in nearly about half of our states right now. There are legal restrictions in place that would complicate the ability for that person to get life-saving medical care in a timely manner. In a complete molar pregnancy, there are often several weeks of obscure ultrasounds, severe pregnancy symptoms, odd HCG readings, and never a baby. So there can be weeks and weeks of hoping and waiting before a loss and surgery, and then the follow-up that comes with molar pregnancy. I've also had a lot of people that I've talked to over time, and less so clients because it is a less common complication. But other people who've lived through molar pregnancies have experienced wide variety of information and education, and many of them are traumatized because they have inappropriately been told, they advised they need a hysterectomy. Their fertility is lost with this, which is not consistent with the medical literature. If you ever encounter someone with a molar pregnancy, I highly recommend going to the Dana-Farber Cancer Institute's website out of Boston. They are constantly updating the best practices, and it does fall under medical gynecological oncology because of the risk and imminence without treatment of choriocarcinoma. So they have clear, concise information that's publicly available. In a stillbirth, the family got so close to meeting their baby, and then there's this devastating turn of events, and the physical toll that a stillbirth takes on a family, the laboring, possibly in a labor and delivery unit with other people making laboring sounds, hearing babies, and there are different traumas that occur in that experience. And I've seen labor and delivery units go one of two ways, where they're hyper focused on emotionally supporting the birthing person and really being mindful, and then others where they're focused less emotionally on the process of induction, too many students, medicalizing the process, and not acknowledging that there are parents in the room who are not going to get to bring a live baby home. With fetal diagnosis, there can be complicated decisions, second opinions, invasive and painful testing, incorrect advice or conflicting advice. Sometimes someone gets a second opinion and it's very different than the first, and having to make these what I call impossible decisions that often come with financial burdens and traumatizing medical experiences. Any sort of termination for medical reason and a termination for non-medical reasons carry traumas in how people are cared for, where they can access care. It is unfortunately still commonplace for people to be told, well, we don't do that here. And sort of there's an implied shame, and go take care of that somewhere else. And there can be a patient sense of abandonment that their provider can't help them or won't help them. And it's not always clear if that's a choice. Whose choice is it? With selective reduction, there's the trauma of saying goodbye to one baby, as well as fear of the health and safety of the other. And in certain states now, the access to that care, where a family is having to make these choices and also doesn't know where they can access that care necessarily. And then not specifically always loss related are birth traumas. And birth traumas, which I'll touch on in more detail, can be reactivated past traumas, avoidable or unavoidable. And anytime they occur at any point in this process, whether a prior pregnancy, a subsequent pregnancy, or the loss, something interrelated of the loss timeline itself, it compounds the grief of the loss itself. Someone is trying to wrap their mind around the loss of the baby that they very often wanted and were looking forward to welcoming into their family. And then they're violated, they are traumatized by something that happened, whether avoidable or unavoidable. I'm going to take you through distinguishing those as we go along. Loss and termination specific traumas deserve some extra attention here. And particularly in the context of the socio-political climate, and whether an abortion is wanted because whatever reason. I don't want to get into the reasons, not because I am afraid to talk about politics. I'm not, but because I don't want us to come up with a list, a metaphorical or theoretical list of what's appropriate, because that gets really dangerous into passing judgments and then supporting the enacting of restrictions on birthing people. So whether an abortion is wanted versus needed, a patient may have more or less access to that care. They may have more or less support and empathy from healthcare providers. And when it is needed over wanted, something that I can't entirely too frequently see is the use of scientific terminology. Someone's getting an ultrasound and there's a normal developing baby on the screen. Look at your baby, look at their feet. They have your nose. These little sonographers and medical professionals can personify a baby quite readily when they think everything's okay. When that suddenly changes, there's a switch that gets flipped, and suddenly we're talking about fetal tissue. And the pregnant person might have a registry, they might have a nursery, they might have a personalized monogram stocking or a wooden sign from some local vendor on Etsy already made up. This baby may have a name, and suddenly they're being called fetal tissue, which can be incredibly offensive and hurtful. There can be a pressure to or a lack of choice in termination. I've had clients who within moments find out that there is a fatal anomaly and the doctor says you should end this pregnancy right now. And that's a lot for someone to digest. And that's 2 to 3 minutes of a doctor's workday. And that disconnecting emotionally from the patient and their family and the lived experience of the people involved can be incredibly traumatic. How someone is spoken to in these times of loss is very relevant. Logistics, navigating logistics of termination, often involves going to a new provider or going to a foreign place you've never been. If this is a first or a first pregnancy, first birth experience, to suddenly be uprooted from the only provider one has known can be scary. And it can be both scary and disappointing if there was a provider someone had a positive relationship with and they're told, I can't help you, or I won't help you. Logistics also can include care of children who are at home, time off of work, especially if it's not safe to or someone doesn't want to disclose. And then there's always a risk of incomplete procedures, retained placenta, needing to return to the hospital, having an infection. Those sort of medical complications can be traumatic, especially if there's hemorrhaging, fever, fear, any sort of sickness that comes out of the process. And in the current climate where clients are having to travel to different states, it can be even scarier, because if someone leaves to go to a state where they can get the standard of care that they need and then goes back home to a state that's forcing birth, then where do they safely get care if they suddenly have a 103 fever? And who do they confide in? Who can they talk to? Disclosing to family, friends, and coworkers can be traumatic and difficult. And well-meaning people who don't know that someone has had a loss can traumatize someone, putting them on the spot, putting them in an uncomfortable position. And as mental health providers, I constantly am encouraging clients to take the space and allow them to put themselves first. You do not have to make other people comfortable. But there can often be this sliding into a caretaking where you client shares news of a loss, and then they're suddenly comforting someone else and putting their grief on the back burner. It is uncomfortable when a baby dies. It's very sad. It's upsetting. It is awful, and you don't need to make someone else feel better about your baby loss. So giving clients permission to not caretake or rush to comfort others, and honoring that is uncomfortable. Much of society doesn't like to talk about loss in this way. Honoring relevant dates and anniversaries. There can be trauma, especially if there were friends who have similar due dates, or there's a baby shower, or Mother's Day can be a big trigger. I know we're just a couple of weeks from that, a little over a week. And when there's a termination that was inferred to be elective, there can be shame and guilt that I chose not to have a Mother's Day. I chose not to get to be eligible for Mother's Day. I don't count. And Honoring people who identify as a mother, whether or not they have a child with them, can be a really powerful, compassionate intervention. Access to care can be traumatic, as I've sort of mentioned before, and there are some really powerful and critical intersectional disparities to highlight around this. There are a disproportionate number of people of color who are in states that have enacted forced birth laws. There are also a disproportionate number of people in need of abortion who are people of color. So the statistics show that if you are not a commercially insured, white, wealthy, or middle-class woman, you're disproportionately likely for at risk for unintended pregnancy, pregnancy complications, whether maternal or fetal. Maternal mortality rates in this country are worse than any other developed country and exponentially higher for Black women specifically and other individuals of color, Indigenous, Hispanic, and Asian populations are all at elevated risk of complications and needing reproductive care and losses that go with that. And they're also more likely to be in maternity care deserts, to be uninsured or underinsured, to have transportation and childcare obstacles, to lack time off of work. So there are a lot of intersectionalities where racism plays into the access to care and amplifies the traumas that people can encounter. And BIPOC communities are disproportionately negatively impacted by the legislation that we've seen roll out in the past year. Other traumas to think about include cultural specific considerations, and coming from a curious stance here is just critical because we don't know what we don't know. So what does it mean for a person culturally to be considering termination or have had a termination, to be disclosing that to a healthcare provider? Based on where they live and what sort of healthcare access an individual has, can they even access accurate medical information? And what about care? The Hyde Amendment is a federal amendment that was put into place related to Indigenous care and is connected to Indigenous land. It used to be called the Indian Health Service. Indian Health Service access to care and abortion is greatly restricted there. So individuals of an Indigenous origin who get their care through the Indian Health Service, for example, can't get abortion care when medically needed. So many of these individuals are facing the trauma of their baby being sick or dying, or they need a termination, they need a D&E because they have lost a baby, or an induction for whatever reason with a stillbirth is contraindicated, and they can't get that because of legislation that's been longstanding. We want to wonder what is the person feeling and thinking about their means, their providers? Is there fear of criminalization? Can they catch up on the rapidly changing legislation? Do they know what their rights are, and do they know what's safe? Is their culture impacting how they disclose anything to a healthcare provider? Are they navigating a deep, dark secret in a devastating crisis? And are there cultural implications for how they might interrupt a pregnancy if recommended? I have had clients who are very committed to their Catholic faith who were advised they needed to terminate and chose induction instead, for example. So they were conscious and physically involved in the process of losing their baby loss. And there are pros and cons to that. And those clients have consistently, even though they've had different providers, encountered judgment of medical professionals. There can be really powerful opinions about that. And that goes into who can I trust, not just a criminalization, but how am I going to be treated with dignity and respect and be able to maintain my autonomy? Or is part of my trauma tied to being judged, shamed, or criticized for my choices? One of my clients, for example, was very shamed. The nurse said, "You're going to want medication for this." And she wanted to be awake and aware and alert for the birth of her baby who was going to pass away, and was very highly criticized. The nurse was very arrogant and convinced that this woman was making a ridiculous decision to not seek out effectively narcotic pain medication. But the client wanted to feel the birth and wanted to feel her baby coming out, and having that birthing experience was really important to them. And it didn't derail that. Ultimately, she was able to have that, but there was an unnecessary and completely avoidable trauma in the way she was spoken to and judged about it. I've touched on financial insurance means transportation, and those different access to care factors. I also want to point out that termination is also disproportionately inaccessible to LGBTQ folks who are at higher risk for needing termination care and also face societal obstacles to getting timely care. So that is something that we have to consider when thinking about treating LGBTQ people of reproductive age. Something else to consider in that is that testosterone hormone replacement therapy can mask early pregnancy symptoms, even if someone's taking hormonal therapies, that may result in them not experiencing any pregnancy symptoms until after a trigger ban or an early cutoff has been put into place. So this is my model of birth trauma. These are the broad categories that I think most traumas fall into. Reactivated is when a past traumatic experience, whether birth related or not, is triggered by a current experience. I haven't thought about that in years. I didn't connect the two. Suddenly I'm dissociating or having traumatic stress symptoms. Unavoidable, we can't help what's happening. We can't help that it's traumatic. We can't do anything different, but we can debrief and we can call it what it is. In our litigious society, I think sometimes there's a reluctance to debrief and not wanting to take on blame or worry about opening someone up to liability. But the debrief can be done thoughtfully and compassionately without opening up to liability. And there are actually some studies that say when healthcare providers talk to patients about what happened and give them an opportunity to share what was traumatic or to talk about something that was traumatic, they're less likely to file a complaint. So it can actually be counter to what some providers think. How avoidable is the prickly one. That's an uncomfortable one to talk about and important to challenge and educate about. That's when avoidable trauma occurs when how care is provided creates additional traumas. I'm going to go into these a little bit further. So common examples of reactivated trauma include a prior physical or sexual assault, any sort of child abuse, even if it was non-sexual, being controlled, contained, being upset, scared, traumatic events that can happen. I've had clients who've had unrelated an ankle surgery, for example, and being in the hospital and not able to move was a really triggering event during their loss. Needing emergent or urgent medical care, often in a new setting, can be very traumatic. Being out of control, the loss or death itself. And it can also be environmental, whether that's a child protective services referral, or it can trigger that past trauma. It can also be scary to be thrown into sudden new medical providers if someone was in foster care, for example, and having stable, consistent people they trust, suddenly they're taken back to when child protective services put them into foster care. They didn't know anybody, or they were getting a welfare check at a hospital because of something unrelated to pregnancy, birth experience, but just being in a new hospital abruptly is terrifying and traumatizing. Something else to consider when there are inductions or birth experiences with a stillbirth or with a choice to induce are familiar sensations. Many physical experiences of birth closely mirror those of abuse. There's some degree of fear that can be expected in childbirth, whether a first or fifth pregnancy. However, the unknown can feel very dangerous to an abuse survivor. Feeling the ring of fire as a baby crowns, seeing blood after a birth or during a miscarriage can be highly traumatic and reminiscent of bleeding in the genitals after sexual assault. Thinking about being examined during a contraction, the physical pain and the bodily response, the timing of that can trigger a physical memory. And sensations of contractions can bring back physical memories. Feeling out of breath, having coached breathing, or being coached along by people in power can mirror the conversational exchange between an attacker and a victim. And people often don't notice it. I've seen providers think they're being encouraging and they're using sweetie, honey, other terms that outside of a hospital wouldn't be really appropriate to use for an adult birthing person. And there's this attempt to be supportive that comes across fairly differently to someone who is a survivor. Through the COVID pandemic, mask wearing in healthcare settings added another layer of trauma for a lot of people. There's the inability to fully read someone's face and that biological need to see someone's whole face and take that um, intuitive information in, and the sense of your face being covered, especially if your breathing is labored, you're distressed, or you're laboring. It can impact someone's perception. Even, I'm sure many of us have seen those oxygen saturation monitors at masks early when there was mask skepticism in the pandemic. People were saying, I can't breathe with this. There's a feeling of not being able to breathe, even if your oxygen saturation is low. And that's where something we also want to tune to the fact that the medical record might not reflect what the patient experience was. So someone's O2 sat level may be documented that was fine the whole time, but they felt they were suffocating, and that can be reminiscent of a hand over the mouth, or someone's screams being muffled, and just feeling contained can be incredibly triggering. Unavoidable traumas. So things that are out of control, anyone's control, but inherently traumatic. Some people experience this in the loss itself, that unfamiliarity that I've mentioned time and time again, because it comes up in so many ways. Blood loss, the traumatizing visuals. If someone hasn't had a loss before and is miscarrying, especially with mifepristone or mifeprex, they are often bleeding more than they have ever bled before. They can hemorrhage. There's that risk of hemorrhage with a natural or medically supported loss, a medically initiated loss. And that can be terrifying. I have had clients hemorrhage pretty significantly, more so than would be biologically seen as normal. And that's scary. And there are people who require blood transfusions because of the loss related to a miscarriage. And it might be medically indicated, they actually lost enough blood to need a blood transfusion, or, their hemoglobin is tanked. But it also just might be more than they've ever seen before. Someone who typically has light menstrual cycles or never has clots in their menstrual cycle and is suddenly seeing large clots and tissue pass can be very scary. And I've heard more than one person say that they thought they were dying. They did not know what was happening. And if this is happening at home in a setting where that wasn't expected, or they weren't educated adequately on what to expect, the scariness and fear go up, and there's more risk of trauma. The physical pains related to loss, medication, induction, delivery, the physical soreness after, and those physical experiences are amplified by the absence of oxytocin and the excitement and joy of a pregnancy that resulted in a live baby. There is no positive feedback, no oxytocin loop there. Having to say goodbye, of course, threatened or actual loss of fertility, loss of fallopian tube, emergent hysterectomy, uterine rupture, or anything where somebody may be told there won't be another chance. A NICU stay, resuscitation attempts, whether successful temporarily, longer term, or failed, hypoxia, oxygen deprivation of the baby that leads to lifelong impacts. COVID implications in past losses are still affecting people, even if restrictions have been lifted. And I have had clients have COVID in the past year and have a loss and wonder, was that connected? Was it not? And then the implications in years prior, where clients may be coming to you with past traumas, are vast and numerous. That being pregnant alone, having to go into ultrasounds alone, get really bad news alone, going into pre-op alone, not having a doula or the supports they wanted in the hospital because of COVID policies. So that's unavoidable. These policies were put into place because of a medical necessity, but that doesn't mean that they weren't traumatic. And then some abstract losses that can be unavoidable. There's vast variation around culturally and personally held beliefs and feelings about privacy and modesty. Anticipated or imminent loss can mean an abrupt change to the care plan or the birth plan. Depending on where the client resides, they might need to research and secure travel. young pregnant people may have minimal experiences with any other providers, and that can go for any age. Good consent that's kind, that includes kind and compassionate care, can be traumatizing, and it gets overshadowed by the loss itself. There's also the loss of time, the loss of the timeline. What did we envision for our family? Whether it's how many children we envisioned having, or how much time I have before menopause, before I don't have any time left. The loss of embryos if fertility treatment was involved, and potential limits on insurance limited that those abstract losses aren't outwardly visible, but they impact how the traumas are experienced. Those who do not know, and also those who know and don't handle it well. So someone who suddenly falls into that caretaking role, and it's okay, we got good care, or they're suddenly caring for the person who had asked them about their baby, and having to disclose repeatedly can be traumatic and isn't always seen as loss, because we're talking about the loss itself and not, well, what else was hard, what else was difficult, what else was traumatic. And then we have avoidable trauma. This is the one I promised you was prickly. So this is the toughest to talk about, but possibly the most critical to tune into. Avoidable traumas occur not based on what's happening with the pregnancy or the baby, but how a person or family is cared for, treated, spoken to, how scenarios are handled in crisis. So, and in this slide, because I packed a lot in here, I want to give some gentle ideas as to how we can address these. So it can be really traumatic to have many individuals involved in care. Culturally or personal preference or survivorship status can impact the comfort of male healthcare professionals being in the room or doing procedures. Some people actively seek out all female practices for a sense of safety, security, or preference, or cultural reasons. So minimizing new faces is something that's really useful. Rushing around is something that people do just because of understaffing. And I encourage anyone supporting someone through any sort of perinatal care to pause and breathe, build rapport, share your sympathy, and offer what you can. I'm so sorry I can't fix this. Is there anything I can do to help this feel less awful today? Making sure to give clear, specific information and slowly. Many people are in a haze during a loss. They're going through the motions. They may dissociate, disconnect from their body. It's a lot to take in. So after explaining, ask and then ask again, checking understanding, confirming consent, and inviting questions. One of my favorite midwives is well known for saying, what else? What else? What else? And until you give 2 or 3 what else's, I don't think there's anything else. She'll keep going. And it's such a simple gesture, but it conveys implicitly that I'm not in a rush, and I'm here to make sure that everything you wonder or aren't sure about is answered. Check in about pain, reaffirming consent. Did it really make sense to someone what you just said? Does it actually feel safe to say no to you right now if they're not okay with something? And being okay with that, conveying that it's safe to say no or yes, not just yes. Acting and speaking without cultural humility can be incredibly offensive and traumatic, and just being aware of that and learning, asking, taking a curious stance. Many clients experience avoidable trauma by aggressive, rough, or painful exams, and procedures done with inadequate or no consent. So there are these kind of crimes of ignorance, if you will, or acts of inadequacy. And then another layer of avoidable trauma is more active, and that is obstetric violence. So this is outward abuse. And the countries of Venezuela and Argentina are the 2 countries in the world that have active, pretty comprehensive legislation against obstetric violence. It is a crime. So someone can have their license threatened or taken away, and they can be charged criminally if they are found guilty of obstetric violence. What's key here is the individual's experience. So the medical records may not reflect this, particularly if an abuser or perpetrator is the one doing the documenting. So somebody is not going to document in a medical chart, I wanted to do a pelvic exam, the client said no, and I did it. The client might be medically gaslit. It's not that bad, or it always hurts. It's not a big deal. Just breathe. I'm almost done. these subtle little things, ignoring, stop, wait, or being told kind of coercion or false narratives. We have to. Do we actually have to do something? And in theory, if a client has autonomy, they don't have to do anything. So the autonomy being stolen from the client is a common occurrence in obstetric violence. And there may not be time for consent sometimes, and that is a different context where there may be an emergent shoulder dystocia, a sudden drop in vitals, something that puts someone's life at risk if a death is not imminent. In stillbirth or inductions, anticipated losses with a fatal diagnosis, a lot has to change. We have to step outside that box and think about, is this an actual emergency if the baby is anticipated not to make it or the baby has already passed? How does the state of the baby influence what is and is not urgent, have to, need to right now? And how do we both inform the birthing person and keep them safe without disrespecting them? It can be done. When medical providers are quiet, that can also be scary and traumatic. They might only speak amongst themselves. Not updating a family can be traumatic, and that can be seen as verbally and emotionally abusive and manipulative. In scenarios in which they're teaching hospitals, having students come in without actual consent to have students can be considered obstetric violence. And I have had clients just liken that experience to what they thought a gang rape would look like. So 5, 6 students gave me a pelvic exam. I had one client who had never had a male provider before, and 5 male medical students examined her while she was laboring for a stillbirth. And she's not the only one that I've had that kind of experience with, and it's just overlooked. Or people are told, this is a teaching hospital, it's what we do. Well, no, you have a right to get medical care without an infinite number of people providing intimate exams. So those sort of experiences, they really resonate with people. And the way people are talked to, as I said earlier, imprints on people's minds. They remember what is said to them and how they're spoken to, whether very positive or very negative. And little things make a big difference. Things that are told to clients. Serena Williams was medically gaslit when she was told she was probably just tired from giving birth, when she said she was pretty sure she was having a blood clot. And she has a clotting disorder, and she almost died postpartum because she had to fight to get the care she needed. And I don't know if you're not familiar with Serena Williams' story with her first baby, she's pregnant again. And she said, I need a CAT scan right now. This is not good. I know what's happening. And she was told no. She was gaslit. Well, if you're just tired, go calm down, go rest. And she had to fight. And they actually didn't want to give her a CAT scan. The doctor compromised and said they would give her an ultrasound of her legs, at which time they discovered, oh, there is a clot, and then sent her to a CAT scan. And thankfully, she did have enough time. But that's not the case for a lot of people. And if you are not Serena Williams, and Serena Williams can't get this care in a respectful and timely manner, how many other people who are not famous tennis stars have access to that care or are being taken seriously in an immediate, timely manner? Some more medical intersectionalities to be mindful of. As I said, BIPOC individuals are more likely to be discussed. They're more likely to be blamed. So they're more likely to die, to have complications than white counterparts. They're also more likely to be blamed and discussed in terms of behavior, low income earnings, assumptions about income, education, and marital status. Before we got started today, I was sharing with Jennifer, I once had a client who had given birth with a practice before and was birthing a stillborn baby. And the OB on call walked in and asked, so is there a father? Presumably, she and I agreed it was presumably because she was a woman of color, despite the same OB group having delivered her first children. These assumptions have nothing, that's a medically irrelevant question done in a really cruel and callous way with obvious racist assumptions. There are public health campaigns. There's this outward assumption that certain factors in birthing people aren't the system, but it's outward problems. Oh, it's diabetes, it's heart disease, it's the obesity, these co-occurring issues. And the light gets shown on public health focus or BIPOC, what I would call a BIPOC blame. And then there's trauma, there's missed diagnoses, there's delayed care, and what I would call medical othering, labeling otherwise. And that also occurs when there's someone having a trauma response. So someone might be labeled a difficult patient if they're having an emotional reaction. And if they've been mistreated by medical care, they might be having a trauma response to that. Maybe their father was dying in the ER years ago and no one was listening, and now they're having excruciating pain and no one is listening. And their vulnerabilities where certain populations are labeled, oh, that's really difficult, or they're so miserable, whatever. And those judgments impact how timely someone gets care and how they feel about how they were treated and what kind of trauma they may be coming to therapy with. And then reproductive history, judgments about pregnancy or termination history, and assumptions that can influence someone's care can be incredibly traumatic. I have had clients who are unmarried and their provider does not agree with that and refuses to take out contraception or remove longer term contraception, or people are guided and steered in directions of certain contraceptives based on assumptions. So those intersectionalities can impact fertility, and they can impact how someone experiences a loss and healing from a loss. When thinking about consent and how all of us as healthcare providers, no matter what our role, can empower people, we can, in the therapy room, we can educate clients on what's the standard, what can I expect from my provider. I want to have reasonable expectations of what's fair and reasonable, and not being a difficult patient. I'm just seeking what I deserve. And we can educate clients about that. We can invite and educate providers and be mindful ourselves of the words we use. Are you using the word decline or refuse, for example? How often has the word compliance come into your documentation? What are the stories providers are creating? What are the narratives that they're writing? How does someone clearly convey, yes, you absolutely can decline? Are they actually giving the pros and cons when saying, this is the reason I want to do something, this is what the benefits, this is the risks, and these are the benefits and risks of not doing it? I see that a lot with vaginal exams. There's a risk of infection. Often it's presented as, we need to check you, we need to see how far along you're dilated. Do we? What if we don't? Is that always essential? What is the reason we need to, and what happened? How do we convey that it's okay to decline? Being very clear, especially in times of loss or related to an anticipated loss, be very clear in educating what to expect physically, emotionally, and visually. I've had more than one provider over the years tell a client, you won't be able to tell it's a baby if you're miscarrying at home, for example. Now you'll just pass tissue and they can make out a head and limbs of a further developed miscarried baby. That's very not okay. It is incredibly traumatic and upsetting to be told one thing and then see something very different. Be very clear about what will happen next and setting those expectations. Something really important to teach clients is that informed consent occurs before, during, and after any procedure. Before means I know what I'm getting into and I agree to go through with it. During, I'm okay with how this is happening. And after, I accept that that's okay how that went. They don't have to like it, doesn't have to feel warm fuzzies about it, but be okay that they said, yeah, that was how I expected based on what I was told. So thinking about how we can help client reclaim some power amidst the devastation, being creative with a client if you're supporting someone, whether it's a nurse in a room about to start an induction or in pre-op, or a therapist helping a client navigate decision-making or plan for a loss. Are there any choices or preferences that can be suggested? I've had clients who are going to need an epidural or be sedated, and somebody just has to catheterize them right away because that's the order we do things here. And so they have an exposing, painful procedure done when they're going to be unconscious in a matter of moments. In my own emergency DNC, the most incredible nurse, her name is Gwen, and I will forever be grateful to Gwen. Gwen came and checked name, date of birth, why you're here, which was painfully upsetting to have to confirm to everyone. repeatedly, at least 8 or 9 times before I was put under. Gwen asked me, is there anything I can do to help you today? Is there anything I can do at all to make this a little easier? And I said, I'm just dreading those awful stirrups in the OR, and it feels so exposing. I knew what they looked like, and I just was dreading that sense of being so exposed. And so Gwen walked me into the OR, and she sat me on the table and said, we're going to let Catherine go to sleep first, and then we will get started. And they did their pre-op consent, and I was put under sedation, and then they did what they had to do. And that little gesture of not having my last conscious memory of staring up at the OR ceiling and feeling so exposed and out in the open made a really traumatic day a little less awful. Didn't save anybody, didn't cost anyone a ton of time, but her simple gesture stayed with me for years later. So what are some suggestions that won't ruin how things are done? Maybe they'll take a few extra minutes, but how do they impact how someone experiences that and tells that story? What's the story you're writing right now with the client? Truly trauma-informed care, treating everyone as if they're a survivor, not forcing a survivor of trauma to have to ask, hey, this is hard for me, I need XYZ. Having everything be organization-wide, not I hope I get, sorry for the typo there, that should say providers. Having everyone in the organization trained to treat people as though they need really informed, thorough consent, as they do, and that they've survived something that could make today difficult in some way. How's the trauma impacting them now, and how can we adapt, just like Gwen did? She's the hero in my story, heroine. Client-led care, empowerment, where can we empower? How can we minimize re-traumatization? And then follow-up, debriefing, counseling support. Everyone who has a loss should be referred to counseling, at least offered that support to normalize that it's traumatic and that getting help can help through that healing process. Whether or not the client takes it, everyone should be offered the same types of supports. I know we're at the end of the hour, so I'm going to speed along my last couple of slides here. Some barriers to care. Feeling intimidated. Clients are less likely to know how to set expectations or to have expectations that they deserve when they're intimidated, feel rushed, they're afraid. There's a visible power dynamic. I like to say you cannot give consent without your pants on. Somebody is laying naked with their underwear across the room. That is not the easiest way to stop and think. There's often desperation, like, let's just get this over with. So taking time, doing consent with clothing on. Most of the time, clients aren't the medical experts. They need thorough, informed consent to be very aware and have comprehension of what's being asked and what the implications may be either way they decide. They may not want to go back to a provider who harmed them. They might not know where to turn, and it can feel terrifying to start over. A lack of understanding is something that many clients have shared as a struggle. In compassionate care by non-medical providers and missed opportunities. I've had more than one client who's experienced a loss and been given still gets the robocall appointment reminders for subsequent appointments, or they had an ultrasound scheduled at maternal fetal medicine and nobody at the office called to cancel that. They show up at the doctor's office for a follow-up and are congratulations, or they're sitting in a room full of pregnant people. So whenever you have a chance to talk to a healthcare provider office or you encounter someone who has a loss, I'll often say to the client, is it okay if I touch base with your doctor and make sure you get the best care possible for your follow-up? And I'll say, cancel any appointments, make sure there's no ultrasound. Don't you dare charge them a missed appointment fee for the appointment you forgot to cancel after they had a loss. And when they get here, take them back to an exam room. Schedule them the beginning of the day or the end of the day, somewhere right after lunch, somewhere where they're not going to sit in a room full of pregnant people, postpartum people with babies. Those little details can matter. There can be a little flag on their file that make things a little less traumatic. When someone is braving pelvic care after a trauma or loss, it's critical that the provider slows down, helps the clients get off autopilot. Non-invasive healing medical care can be helpful too. So I'll frequently recommend clients go to an acupuncturist so they can get some mostly fully clothed healing medical care. It can feel really cathartic to the body to be getting medical care that's not painful and traumatizing. Acupuncture also has some great benefits for emotional regulation, grief, and regulating cycles if someone has future fertility plans. And then if there's pelvic care to happen, talking about inviting a client, or if you're a therapist, you can coach a client through role playing this, talking about introducing the terms slow down, pause, stop, and out. Slow down means I just need a minute, or pause, whatever feels natural for the client. Stop means stop what you're doing, like freeze tag when we're kids. And out means hands up. Just like on Chopped, Iron Chef, time's up, everyone's done, hands out. I don't care if you finished a procedure or not, I want out. And that is a critical part of consent. Educating clients, we can educate and empower, guide them in learning about evidence-based care. Evidence-based birth is a great resource for that. They don't have as much loss information as they'd like, but my website has some, and I love to refer people to Return to Zero, Star Legacy Foundation. Help clients find providers following standard of care who've provided sensitive care to your clients in the past. Set expectations for trauma-informed care. This is what is realistic to expect. If you're getting anything less, take your business elsewhere. Role-playing those provider visits with clothes on, of course. Verbally role-playing those visits in non-medical settings, helping clients find new care to make sure they're maintaining preventive care or follow-up care. Sometimes a client comes in to me right after a traumatic loss and says, I'm not going near that doctor or that office or that hospital ever again. So connecting a client to someone who is trustworthy, who will take good care of them and make sure they get the follow-up that they need to prevent other traumas. If someone has retained placenta or an infection, the last thing I want is for them not to get that follow-up evaluation and then end up in the ER emergently, where they're very likely to get traumatized. And then connecting clients to integrative supports, just like acupuncture, naturopathic physicians can often offer herbal supports and vitamins to help clients replenish. Let's be thoughtful about blood loss. Postnatal depletion occurs in patients who have had a pregnancy loss, not just those who have a live baby. Thank you so much. Right before time, I will stay late if there are any questions. And I also wanted to share that for those of you who are potentially interested, there's an exciting new conference coming up in the next couple of weeks on May 12th, the Legal and Ethical Dilemmas in Perinatal Mental Health. I'm speaking with Maternal Mental Health Now in California and online into next week. So I'd love to open it up for questions. Jen, if you do you want to start?
Yeah, thank you so much. Yeah, thanks so much for all that. One of the things that came up for me that I think is really great to mention too is that there's such a short window in perinatal loss for capturing continued connection for the parents. So that can look like handprints, footprints. It's very much missed and not available or not told. Those choices are not available. Not often, especially the TFMR groups that we do at Return to Zero. We just hear it way too often. Getting to spend time and hold your baby, even if it's uncomfortable for the birthing parents, we find that over time and with their grief, it's paramount in their healing. And getting to get photos or any sort of connection and all the choices available to them. I wish I'd had in many of my pregnancies. And
putting provider discomfort second to parent discomfort and grief. Spot on. I think some of those missed opportunities are a result of provider discomfort with death and loss.
Yeah.
And they're in a position of power. It's like, I can get unconscious privilege flex. This is more comfortable for me, so I won't offer it.
Right. Makes sense. Well, thank you. It looks like Tessa was wondering about, thank you for including the pregnancy loss from a therapeutic abortion that can be felt as a loss and emotionally traumatic, even if there's no physical trauma, or at least that's what she thought you said. And I believe that can be true. And running groups for people who've had an abortion, why there's a lack of lost groups for that population. And Return to Zero, we don't turn anyone away. And we do have people who've experienced abortions in the past. So, and I currently have somebody in one of my groups that has that. So
I believe I know that Postpartum Support International has one, at least one. And I thought Return to Zero had a group related to termination.
Well, we have termination for medical reasons.
Right. I can tell you that I'm a founding member of Postpartum Support International Connecticut chapter and connected to PSI nationally. And I know that because of the socio-political climate, there has to be caution exercised in registration and protecting those groups and keeping them a safe space, because unfortunately there are people with ill intentions who want to hijack their way into those and further traumatize grieving bereaved people. So they can be harder to find, and contacting Return to Zero or Postpartum Support International and going through those channels can be a safe way to help clients connect to those very needed, very valid services. But I do know some of them are kept under wraps because there are some awful, hateful people that have malevolent intentions.
Yeah, we definitely do not
There,
record
yeah,
our,
therapeutic abortions by choice, not termination. Yeah, there. I think that PSI has a termination group, and I absolutely characterize clients who've terminated by choice as bereaved. It's what I call an impossible choice. There's no happy, exciting choice. Also, if anyone has ever supported or encountered anyone who has taken a pill abortion, it is no walk in the park. Every client I've ever encountered has consistently said it's the most painful experience they've ever had. Those who've birthed before have said it's worse than labor, and the blood loss is almost always traumatizing. So there is no easy abortion. There is no easy out. When a pregnancy has to be interrupted or terminated, it's devastating all around, and I call it differently devastating.
yeah.
There's no easier, just like parenting. There's no easiest stage.
Yeah, and 4 of my losses ran the gamut of all of those. So an early loss where I naturally passed all the tissues, I was very lucky, and then 2 second trimester losses, and one was done in a medical setting and one was done in an abortion clinic. And then medication for my last one, which I did not expect and did not see that coming, the amount of pain. And yeah, it was not easy. Yeah.
And so when people on political soapboxes talk about how casually it's being passed around, like you really have no clue.
Yeah.
And I'm grateful for the advocates who continue to fight for the rights of pregnant people to make those decisions, because there is no easy decision, and the loss is unspeakable and unquantifiable to begin with, and those additional obstacles just add to the trauma. So I hope everyone's found this really helpful. I'll answer any other questions as if they come up, and thank you so much for having me, Jennifer.
Oh, you are so welcome. It's great to have you. Very informative, very helpful.
Thank you.
Yeah, thanks everyone for being here. And I know probably people have to go, but feel free to drop questions if you have them in the chat. And if not, this recording will be online and will be emailed to all of you. So,
Thank you.
Yeah.
I appreciate all the kind words in the chat. Thank you.
Okay, good. Yeah, PSI is the spot. And Return to Zero doesn't turn anyone away. We welcome. Yeah.
Yeah, the ethical dilemma is at maternalmentalhealthnow.org. It will be recorded. It's in Los Angeles, and there's a live stream. This webinar, I don't believe, has CEUs. I have a birth trauma webinar that I'm renewing CEUs on. And you can find that on my website. And there's Maternal Mental Health Now, another great nonprofit in California.
And then if you have any patients that you want to send to the next webinar Catherine's doing at the end of the month, it's going to be the same topic, but for families. So feel free to send people our way. Yeah.
And know that it's going to be a safe presentation without any sort of judgment or harmful agenda. I think it's so valuable to state that. I hope it's obvious from my presentation that no one will get any sort of harmful or hurtful information.
Awesome.
Thank you. Thank you all.
Thank you, Catherine. All right, we are
welcome.
going to end, and thank you everyone as you're signing off, and enjoy your day, and you too, Catherine, and I'll see you at the end of the month.
I can't wait to see you again soon. Have a good day.
Yeah, you too. Bye. Thank you. All right, bye.